Hello, welcome to today's class. My name is Winnie Barawa. I believe you've heard about pneumonia before, and in this class, I want us to go through what pneumonia is, what causes it, how does it present itself, and what management should we give. Welcome to Medic Academy and enjoy till the end. Pneumonia is actually an inflammatory process that occurs in our lung, but it happens most specifically in the parenchymas, terminal airways, and alveoli. What happens mostly during this inflammatory process is that it leads into a process that produces for us a lot of secretions, what we are calling excess fluids, and most of these processes are due to infections, and these infections can be caused by organisms including bacteria, which can be mycobacterium, fungi, viruses, but in some instances we can have aspiration of an irritant or foreign particles. The starting point of any pneumonia disease is that there is need for presence of either of these factors, be it the microorganism, which can be a virus, a bacteria, or also a fungi. But again, you can also have aspiration of substances, which could be fluids, solid matters, or any other substance that we may end up swallowing or aspirating into the respiratory system. So once these organisms or substances have gotten an entry into our respiratory system and having an access to our parenchyma or the airways, then it stimulates what we call the inflammatory process. This inflammatory process initiates a process that leads to processes such as redness, tenderness, pain. But as all this is happening, we end up with our airways, that is either the alveoli, the bronchioles, or the lower parts of our respiratory system undergoing bronchospasms and bronchoconstrictions. And as a result, these patients end up with excess secretions that reduce the airways and our ability to take in more air. So what happens is, while all this pathophysiology is ongoing, our patients end up having alveoli that are filled up with secretions, or what you also call exudates. But again, there is presence of excess secretions. So these secretions block these airways and we lack enough oxygen, leading to the state of low perfusions. But then the tenderness or the inflammatory process brings about also edema or swelling of our mucosa in the bronchioles or in the alveoli and other airways. So based on causes, pneumonia can be categorized as bacterial, fungal, or also viral pneumonia. Based on the site or situation, here we are looking at what might have led to the pneumonia or what time made the pneumonia to set up. So in this case, we can develop what we call community-acquired pneumonia, hospital-acquired pneumonia, pneumonia in immunocompromised patient, and aspiration pneumonia. Community-acquired pneumonia, this one is under situation whereby a patient reports to the hospital with a diagnosis of pneumonia, and most of the time this diagnosis should be confirmed within the 48 hours of being hospitalized. So let's use a real case whereby a patient has reported to the ward. They have been diagnosed with a pneumonia diagnosis, but this diagnosis has been confirmed 48 hours within coming to that hospital. So if this has been confirmed within the time frame of 48 hours, then that particular pneumonia will be under community-acquired pneumonia. However, there are certain bacteria or microorganisms that are known to be the main cause of this community-acquired pneumonia. And this includes streptococcal pneumoniae, Haemophilus influenza, Legionella, Pseudomonas, and also aeruginosa. So these are groups of bacteria that seem to have a high likelihood of having led to community-acquired pneumonia. Hospital-acquired pneumonia. So what is hospital-acquired pneumonia? As the name suggests, it's hospital-acquired, meaning our patient got this pneumonia while they already been admitted in the ward. So most of the time they say when this patient comes, they didn't have these pneumonia symptoms yet, but as they kept staying in the ward, they developed pneumonia-like symptoms. However, you need to be keen on the hours or on the timing. If the pneumonia is said to have been discovered after 48 hours or more than 48 hours after admission, then it's being assumed that this pneumonia was acquired from the hospital. So this pneumonia is therefore also known as nosocomial pneumonia, from the word nosocomial, infections. So it's being related that this patient ended up with pneumonia while they had been received to the hospital, and assuming that the patient did not get it from their community. So what are the causes? The causes are not the same to what community acquired pneumonia has. So in this case, we talk about Enterobacter species, Escherichia's, Klebsiellas, Proteus, Serratias marcescens. The group of bacteria that leads to this pneumonia are not the same with what you will find in the community acquired. Certain situations that are said to have led to a patient ending up with a nosocomial pneumonia. And in this case, there could be issues of impaired host defenses. There are clients who have excessive sepsis, or they have severe sepsis, and so because of that, the immunities are already affected, and so they end up with complicating with hospital-acquired pneumonia. The other case is whereby the microorganisms are in large volumes and they tend to overwhelm our patient defense mechanisms. But don't forget about coma clients, whereby they're actually in an immobile state, so they're not able to do body movements. And most of this time, remember, when a patient have a respiratory condition, they have a lot of secretions. So when they're in a coma or in an unconscious state, they're not able to mobilize the fluids and the secretions and cough them out. So this microorganism tends to overwhelm them in the system, and they harbor other microorganisms, including possible causes of pneumonia. Malnutrition is another cause. Malnutrition is known for bringing low immunity as a side effect, and as a result, a patient can develop pneumonia due to infection cases. Prolonged hospitalization. When a patient stays in the hospital for a long period of time, they end up exposed to other microorganisms which can be causing pneumonia. So if a client stays long in the hospital, a client needs to be ensured to be on a prophylactic antibiotics or prophylactic management to prevent them from infections. The other factors include respiratory devices and equipment, e.g. tracheostomy devices, oxygen prongs or oxygen masks, which are majorly most of the management we use when you're handling our pneumonia clients. So now in these devices, if they're not well handled, there's no hygiene practices, we can introduce infection to our patient and infect them with pneumonia issues. Prolonged use of antibiotics is known for leading into antibiotic resistance, a case whereby our patient does not respond to medication. So if our patient stays on a therapy for too long, then the patient may have reduced efficacy, whereby the drugs do not become effective in managing this disease. Now, the risk of that is that if the patient is not responding to antibiotics, then it means the body is exposed into harboring more microorganisms, and this could include pneumonia cases. Nasogastric tubes are also some of the known sources. If nasogastric tubes were the ones we use for feeding are not well cleaned or are not well managed, they can give us risks for pneumonia issues. And lastly, invasive procedures or devices that can include our intravenous entries, such as central venous catheters, can also lead to entry of these bacteria and give us presentations of pneumonia. We have the pneumonia that can happen in immune compromised patient. So in immune compromised patient, I want you to understand that immunity in our body can be affected by different situations, and these situations are what can risk our client to get infected or to obtain pneumonia. So what are these situations that can lead into immunocompromised status? Number one is if there is excessive use of corticosteroids, whereby it's known that long use of corticosteroids brings along the side effects of immunocompromised state. So if clients are overusing these corticosteroids, then you need to look at the long-term side effects on our patient so that you can learn to when to stop them on time. But also you need to know that most steroids, such as hard drugs like bang, cocaine, and heroin, they also fall under this category, but they're hard drugs. So they're also tending to bring low immunity to these users, and some of them end up getting pneumonia also. Immunosuppressive agents or clients who are under cancer management, some of them actually can end up with side effects of having low immunity, and due to this they end up predisposed into acquiring pneumonia status. Nutritional depletion, this is relating to malnutrition, which is clearly known that with malnutrition it's said to bring an issue with lowering our immunity. And if we have malnutrition in a patient, the immunity tends to go down and our patients end up exposed to other microorganisms. Point 4 is excessive use of broad spectrum antibiotic agents or antimicrobial agents, whereby with overuse of these broad spectrum antimicrobial agents, clients might get the resistance as a side effect, and so they end up being prone into acquiring respiratory infections such as pneumonia. AIDS or acquired immunodeficient syndrome, where our patient has gone into the syndrome and they're complicating. So mostly with HIV patients, it's well known that they end up with low immunity because of the aggressiveness of the HIV virus that tends to destroy a lot of the state in our body or in our organs, and so it brings so many complications, and some of it is low immunity. And with our client being on low immunity, then they're prone or at risk of also getting respiratory infections. Then genetic immune disorders. With genetic immune disorders, it's being said that some diseases genetically or genetically transferred disorders tends to have an effect of lowering immunity. A good example is what we call the systemic lupus erythematosus or SLE, which have side effects or complications of lowering immunity and hence leading to these pneumonia issues. The other part is long-term use of advanced life support technologies such as mechanical ventilation. That I want to discuss is aspiration pneumonia, where we have entry of either endogenous or exogenous substances which have access to our lower airways. As a consequence of aspirating the substances, we end up impairing our lung defense, causing inflammatory reactions that leads either to bacterial growth that presents as pneumonia manifestations. Symptoms or clinical manifestations of pneumonia. Most patients present with fever or chills with temperature recording of at least 38 degrees and above. The client has productive cough that involves production of sputum. There is pruritic chest pain that is aggravated mostly either when the patient is coughing or doing deep breathing. There is also dyspnea, which is also known as difficulty in breathing or irregular breath rates. Tachypnea, which is high or faster breathing rate that also is associated with grunting. Then there is nasal flaring, use of accessory muscles, fatigue, and this patient also gives us a rapid bounding pulse. So pulse, you can check it in various parts of the body, including the famous radial pulse. Is of how we can check pneumonia client. So you can diagnose them using a chest x-ray where you want to look for consolidation of the lung tissues. You can use a pulse oximeter where you want to confirm the oxygen saturation levels in the body, and in most pneumonia clients they'll give you a decrease in oxygen saturations if you use the SpO2 machine. Complete blood count will show us elevated white blood cell count, mostly on the sides of neutrophils and also on the side of basophils. Then you need to check on sputum culture. So with the sputum culture, you get the sputum specimen, which goes to the lab, and they're able to do culture and sensitivity for us to see the various microorganisms that are promoting the the pneumonia development. Arterial blood gases, commonly known as ABG. Here you want to analyze the pressure of oxygen and pressure of carbon dioxide, or rather what we mean, the concentration of oxygen in the blood and the concentration of carbon dioxide in the blood. In ABGs for pneumonia, the results will show a decrease in our oxygen pressure and an increase in carbon dioxide pressure. This shows that at the alveolar level, this inflammatory process is causing an impaired state of gaseous exchange, or it is showing that there is no oxygen that is getting absorbed to our system and carbon dioxide is not escaping into the environment. Management of our of our patient using the nursing approach, you first need to learn about generating nursing diagnosis. I know this is where most of us get our challenges at, but I've tried to generate a few lists that can help us understand this pneumonia state. But please understand, in nursing diagnosis, you're always supposed to generate a priority management. So that your diagnosis should be prioritized. Do not start with the risk management. Risk, most of the time, they are put as the last management. The first ones are the priority ones, the things that you're seeing that you need your patient to be dealt with first. So this is my list. I may not have followed an order here, but it's just for the learning purposes. So in this case, for me, I had impaired airway clearance, activity intolerance, imbalanced nutrition, knowledge deficit, and the risk for fluid deficiency. So in this case, in nursing diagnosis, you need to have a relation and an evidence. So as you can see, this is what I got. So there's an effective airway clearance related to copious secretions as evidenced by chest congestions during our lung auscultation. All right. Then there's activity intolerance related to impaired respiratory function and hypoxia as evidenced by our patient presenting with inability to adequately perform activities of daily living. The third one is imbalanced nutrition, less than body requirement, related to the loss of appetite as evidenced by weight loss and reduction in food intake. Fourth, knowledge deficit related to treatment regimen and any preventive health measures as evidenced by patient inability to clearly explain their condition or progress of management. And the last part is risk. So when you talk about risk, the risk for deficient fluid volume related to the high temperatures or fever and rapid respiratory rate. Please understand and note, I did not put an evidence because risk shows what you anticipate to might develop or might develop. So you do not have evidence yet because this has not yet happened. It's just what you anticipate might happen. So in this case, what you do, give a risk, at least it shows you also understand how the disease is progressing and you are sure of your management. Intervention will have improvement of the airway patency. So how do you do this? Work on hydration, give fluids to the patient. Give fluids for this patient. So remember, there's the risk for dehydration here with the fluid volume decrease. So hydrate your patient, give them more fluid so that you can not only clear these airways by loosening the secretions and enabling the patient to clear them, but you are also able to restore the fluid loss. Then humidify your patient. Participate in nebulizing this patient so that you can make the airways humid or moist, and this is one of the ways of encouraging the fluid of the secretions to come out. Encourage coughing exercises to stimulate the chest cavity, to stimulate the breathing ability, and to have your patient pull out the secretions. Give oxygen to supplement on the hypoxia. Give oxygen to supplement the reduction in gaseous exchange so that your patient can also pick up on their saturations and pick up on the tissue perfusions. Because our client has malaise and fatigue, promote rest, conserve on their energy, put them on a comfortable position, encourage them to rest, give them a semi-Fowler's position, which is the best one when it comes to respiratory conditions because number one, it promotes breathing. Fowler's also allows adequate chest cavity so your patient can have deep breathing, they can have proper ventilation, and this is one of the ways to allow you to achieve your saturation and to achieve humidification effectively. So there's easy secretion clearance in this particular position. But also we talk about changing this position frequently. So change position frequently because one position may not be effective. As you keep changing the position, you are not only promoting secretions, but that mobility aspect of your patient stimulates muscle movement, but also is able to stimulate the different breathing abilities of your client. Fluid intake. So we've talked about fluid intake not only for hydration, but to also assist in secretions clearance. But also understand the fluid intake is being done to help in preventing dehydration. Unless it is contraindicated, you need to understand that some patient may come with pneumonia, but they could be also battling cardiac conditions. So in this case, you need to watch out and ensure that your patient is not contraindicated from fluids. Management, maintain nutrition. So you want to maintain nutrition by giving more of calories and balance it with the electrolytes. So with this, you want to be all round, have a balanced diet for the patient. Electrolytes are good, but mostly you get this via fluids, Ringer's lactate, normal saline and all that, but also work around getting balanced diet for our patient. Work more on calories because our patient doesn't have energy, so you need to boost up the energies. Promoting patient knowledge by explaining to them things like the cause of the disease, the management of symptoms, and need for having a follow-up through the different outpatient department after discharge. So educate them on this because one thing about patient education is that it promotes cooperation and it allows your patient to adhere to the regimen and the different discharge activities that you might allow them to do. Then learn to monitor and manage potential complications. Know that pneumonia can bring out different complications such as atelectasis, respiratory insufficiencies, and so on. But learn to be able to pick up signs and symptoms that might indicate that your client could be complicating so that you can intervene on time and protect your patient from those further complications. So here is a summary of all this management that I've been talking about. And remember, I mentioned that there's viral and there's bacterial pneumonia and there's also fungal pneumonia. So what I gave was the general management for all the pneumonias, but I need you to know sometimes our management could just be classified based on what has caused the disease. So let's look at viral first. So viral pneumonia is said to be symptomatically treated, but the main focus is also working on promoting oxygenation, position the patient, administer oxygen levels based on what has been prescribed, but also work on postural drainage. Change those positions, allow the secretions to be mobilized and be secreted, nebulize, sanction if you have to. Give antipyretics to monitor the high temperatures. Be strict on the input and the output charting. Remember, we are worried about dehydration here, so check onto that. And then work on family support. Talk to the family, let them also be part of the management, explain the cause, explain the progress, let them feel like they're part of you. In bacterial pneumonia, there is also supportive and symptomatic management here, but here you also want to check on temperature, so you give on antipyretics, oxygenate your patient for humidifications, put the patient on a comfortable position. We have already proposed the semi-Fowler's position. Put your patient on antibiotics, then do close monitoring of the status of the respiratory system. How is the breathing rate? Is it shallow? Is it deep? Is it irregular? And then check on other vital signs that could help you check on the progress of the client. Restrict or be strict on the input and output charting again. Normally, because here we have IV fluids that we are working on, so learn how to put in the input and the output charts. encourage the fluid intake because you want to prevent the dehydration status. Sanction if it is necessary. If you feel like this patient is congested and the secretions are so much, and this is if you have observed physically or you have done your lung auscultations and identified the status of chest congestion, go ahead and sanction. Do nebulization, mostly with bronchodilators, to open the airways and clear the secretions to allow flow of oxygen or to allow air entry in the system. And then if it's a child, talk to the family, engage the family, let them understand the disease and how the patient is progressing. And then always encourage rest and discourage excessive or vigorous activities. Remember, we said our patient is fatigued or malaged and you do not want to be excessive on their physical engagements. Complications might come. I found this and I really loved it, which says, don't slap her. It's an acronym to help us get the different complications of pneumonia. Don't slap her. So in these complications, we get septicemia, there's lung abscess, there's ARDS, which is acute respiratory distress syndrome. We have parapneumonic effusion, okay? We have hypotension, there's empyema, and then we can have respiratory or renal failure. So don't slap her. Thank you so much for being with us all the way to the end. And if you keep appreciating what we do in this channel and you wish to come back and be notified when we post in new content, please like, comment, share, and subscribe to be part of the Medic Academy. Thank you very much and see you till next time. Bye bye.